about primary congenital glaucoma, an overview. So when we talk about congenital glaucoma, we have to classify the childhood glaucoma. This is based upon the childhood glaucoma review network, primary childhood glaucoma and secondary childhood glaucoma. When we talk about primary childhood glaucoma, it includes the primary congenital glaucoma as well as the juvenile open angle glaucoma. When we talk about the secondary childhood glaucoma, which is divided into again, which are associated with non-acquired ocular anomalies, it can be associated with non-acquired systemic disease or some of the acquired condition or even glaucoma following cataract surgery come under this. When we talk about primary congenital glaucoma, when it happens between 0 to 1 month, it's called as neonatal. When it comes beyond 1 to 24 months, it's called as infantile. And when it is beyond 2 years, it's called as late onset or late recognized congenital glaucoma. A thorough assessment of these babies is very essential. A thorough history regarding the gestational history, whether there is any family history, any other siblings of the baby is affected with a similar condition. Then, of course, the general condition of the baby is also important, whether any systemic illnesses are associated with, because when we give certain drugs in glaucoma, we need to understand whether the child can tolerate the drug or whether it is associated with any other side effects. Of course, a good ocular history, whether it is associated with any other condition, is it a syndromic condition which we are dealing with, is important to understand. Like sometimes aniridia can be associated with it. So whether it is associated with any other ocular conditions or an ocular history like watering, discharge, when did the parents notice any kind of a symptom, either a visual symptoms or any other symptoms, when the parents have noticed, is important to understand. And of course, about the photophobia or intolerance to light, that's the time when many of the parents come and complain to us. And many parents notice a corneal haze. And of course, a thorough pediatric history is also important because we may have to give the child general anesthesia. So that way, systemic history is extremely important. What is a classic triad of symptoms? It includes epiphora, photophobia, and blepharospasm. This is the classic triad which we call in congenital glaucoma. How do we examine these children? So either if the kid is cooperative, we can even examine in our examination room or in our office. Otherwise, we have to take the child under anesthesia. So these are the ways which we can examine. Now, when we talk about examination under anesthesia, there are certain perspectives which we understand is about anesthetic choices. So usually, most of the time, we use sevoflurane, which causes a progressive IOP reduction. Some people use sedation with chloral hydrate, and usually ketamine, it doesn't have much of an effect on the IOP. So we should understand what is the effect of anesthesia on the IOP when we do examination under anesthesia. So this is these are the examination under anesthesia box, which we call, wherein we use like, there is saline, there's a vernal calipers, there's a speculum which is used. So these are some of the basic instruments which we use. So as soon as the child is given anesthesia, we can check the intraocular pressure either using a tonopen, eye care tonometer, or a Perkins tonometer. Of course, a refraction is mandatory. Then a corneal diameter, as you know, horizontal and vertical corneal diameters have to be checked. Then we have to do the pachymetry readings. Then other investigations include a biometry or an A-scan evaluation. And then we have to the patient has to undergo some certain special investigations if required, like UBM, perimetry, etc. So when we talk about the intraocular pressure, we can measure either as a GAT, that is using a Perkins handheld tonometer, or even in the office room, we can use a GAT. That is the applanation tonometer, then tonopen, or an eye care tonometer. So IOP in children is generally much lower than that in adults. It was noted to increase with age, hyperopia, and the corneal thickness also. So this is an eye care tonometer, which is much comfortable nowadays because it doesn't need an anesthesia. So the patient, the children are much more comfortable to use the eye care tonometer. And then we do have eye care tonometer, which can be used in the lying down position as well. Now, when we talk about the corneal findings, normally the corneal diameter is around 10 millimeter. It keeps increasing by 1 millimeter during the first year. So when it is greater than 11 millimeter in a newborn and definitely in 12 millimeter in an infant is considered significant increase. And as you see here, there's an increase in corneal diameter and central corneal thickness or the pachymetry is to be measured, wherein the CCT also increases with age when considering 1 to 11 years. So an average of around 500 to 550 is usually noticed in the newborn children. Of course, refraction is mandatory because visual rehabilitation, if required with glasses, is also important as part of our treatment modalities. Then fundus examination, any cup disc ratio of more than 3 in less than 1 year or more than 5 in older children is definitely significant. So the fundus examination has to be done. If not, then probably a B scan is indicated. Gonioscopy, usually we can do if the baby is under anesthesia, then we can use a direct lenses like a Swans-Jacob or a Copace lens. So in the normal newborn eye, the iris usually inserts posterior to the scleral spur. In cases of primary congenital glaucoma, usually we see a flat insertion of iris. Then these are some of the terms which is important in an exam perspective. Loops of vessels from the major circle can be seen above the iris, which is called as Loch Ness Monster phenomenon. And the peripheral iris again can be covered by a very, very fine, fluffy kind of a tissue, which is called as Lister's morning mist. These are some of the findings which we may encounter when we do a direct gonioscopy. Of course, axial length is important to check because that also can give us a clue about the intraocular pressure control. The steepest growth rate usually during first year, it increases gradually 4 to 5 years, and usually it kind of plateaus by 6 to 7 years. So in a study by Hussain et al., the mean axial length at birth was noticed to be around 16.8 millimeter with a rapid initial axial growth and with a mean axial length of 20 millimeter at 12 months of age and 21 millimeter at around 4 years. Other ancillary investigations which may be indicated, as I mentioned, B-scan may be indicated if fundus examination is not possible. Again, UBM in case we find that there is other causative factors where we need to check for a ciliary body or an iris configuration. Of course, if it's in older children, we can try doing a perimetry. Differential diagnosis of this condition, it can be divided into as per if the patient or baby is having epiphora, then what are the other things which we should keep in mind, like congenital nasolacrimal duct obstruction. Of course, you have to rule out a conjunctivitis, which can be associated with severe redness and a yellowish virulent discharge. Corneal epithelial defect or an aberration has to be ruled out, and of course, any keratitis and any inflammatory conditions. If you're noticing only a corneal enlargement, then probably we have to rule out an axial myopia and much more common condition like a megalocornea. If the cornea is hazy or there is a corneal edema or opacification, whether the child birth history gives a forceps related history, so then maybe we have to rule out a forceps related birth trauma. Another common condition which we see is CHED or congenital hereditary endothelial dystrophy or posterior polymorphous dystrophy. Of course, sclerocornea kind of a picture, Peters anomaly, and other metabolic diseases like mucopolysaccharidosis. Now, when you look at the optic nerve head, it can be sometimes physiological optic nerve head, and we have to look for whether are we dealing with a PITS or a coloboma, or is it really a large disc? And of course, if it is associated with myopia, sometimes you can get a tilted disc. If it is only increased intraocular pressure, sometimes just a maternal rubella syndrome can be associated with increased IOP, which many a time we have seen that it comes down gradually over the months. And it can be due to other secondary causes also, whether are we dealing with secondary infantile glaucoma. So this differential diagnosis should be kept in mind before we label the child as a primary congenital glaucoma. So that's a most common non-syndromic glaucoma. So usually it happens in 1 in 10,000 births in Western developed countries. So as per the population-based assessment of childhood blindness in Southern India, it was noted to have 1 in 3,300 in Andhra Pradesh. So usually it is inherited as an autosomal recessive manner. Definitely there is an increased incidence in consanguineous marriage, and there have been a lot of genetic studies associated. So usually there is a 3 loci which is seen, and the gene which is common associated with is CBP1B1. A slight predominance is noticed among males, and the involvement is usually, most of the time, 70% almost, it is bilateral. So this was a study done in South India to analyze the profile of childhood glaucoma, and it was noted to have around 37% of primary congenital glaucoma, when 85% was bilateral, and other conditions which were included were some of the acquired conditions was steroid-induced glaucoma and a traumatic glaucoma. What are the theories associated with congenital glaucoma? So there have been umpteen theories starting from 1928 to what is postulated to 1985. So it has been associated with atrophy, resorption, incomplete cleavage of mesoderm, and Baumini again in 1958 said abnormal anterior insertion. And more recent ones like 1971 Smeltzer and Ozanix have hypothesized a failure of rearrangement of angle structures into normal trabecular meshwork. And in 1985, Westerkamp postulated an abnormal ECM and a glycoproteins. Now, coming to the most important part, the management. When it comes to medical therapy, it is only a supportive therapy which we can give either before the surgery and after the surgery. Beta blockers, topical carbonic anhydrase inhibitors, prostaglandins, oral carbonic anhydrase, and IV mannitol, they're all considered to be safe among children. Only thing is that we have to take a detailed history and make sure that none of the contraindicative factors are in the child. And when we give the child, suppose before the surgery, oral carbonic anhydrase inhibitors, make sure that it is dose related, 5 to 15 milligram per kg per day can be given to the baby. So as you all know very clearly, medical management is only a supportive therapy. The real actual management involves surgery. Now, what are the challenges to do a successful surgery? Now, you have a large eye, you have a ophthalmic eye wherein there is a distorted anatomy. And some of these anatomical features or some of the secondary glaucomas like an accent field, or if it is associated with any of the inflammatory glaucoma, again, there can be a change in the anatomical features. If the baby has undergone any kind of previous surgeries, that also hinders your successful surgery. Aggressive healing response and the inflammatory response in children. And of course, difficulty of administering care. Sometimes we may not be able to put the drops or the post-operative medications, or post-operative care might be compromised considering the age of the babies. Now, what are the different surgical modalities which are available? Now, one of the common surgical modalities is goniotomy, which is usually performed when there is clear cornea. So we do use a direct gonios lens like Swan-Jacob lens. That is the most common lens, and then you can use to do a goniotomy a Barakur knife, MVR blade, Wurst knife, Swan spade, or even a long needle can be used as a goniotomy knife. Some 23 gauge needle also can be used as a when we perform a goniotomy. So usually the reported results of goniotomy surgery has been around 80% in infantile glaucoma. This is a small video to understand. So this is a Swan-Jacob lens. So when we perform a goniotomy, one of the most important thing is the positioning. So usually the microscope is towards the surgeon and the head of the baby is put away from the surgeon to visualize the angle. So once we place the Swan-Jacob lens, the anterior chamber is filled with the viscoelastics, and then we can use either a long needle to do the goniotomy procedure, and visualizing through the Swan-Jacob. This is the surgeon sits in the temporal side and the nasal angle structures are visualized and the goniotomy is performed. So this is turning the needle again and performing the other 180. So almost 180 degree can be covered by sitting in the temporal side. So what are the advantages and disadvantages of this procedure? Now, disadvantages are it does not violate conjunctiva. We're not getting any conjunctiva cut or anything like that. Visualization of angle allows precise incision and it is repeatable. We can repeat the procedure in other angles also, and blood-related complications are not there, and very, very minimal risk of baby eyes going in for hypertony. Coming to the disadvantages, yes, it is little technically more difficult, and in hazy corneas, it may not be possible to visualize the angles, and it just requires a special instrumentation, that's a direct gonio lens, and you might require an assistant to fixate the eye. And it has to be repeated. Sometimes a single goniotomy procedure may not be adequate to achieve a good IOP control. Other procedure which is commonly performed is called as trabeculotomy, and this is a conventional probe method which is like using a conventional probe, that is the Ham's trabeculotome, and then you can use the circumferential or suture or catheter trabeculotomy as well. Now there are multiple methods to do the trabeculotomy. You can use multiple blades, multiple instruments to use the thing, but the conventional one is using a Ham's trabeculotome. Now, what are the advantages of trabeculotomy? It can be done in opaque corneas. As I mentioned, the goniotomy may not be possible in AC corneas, and 360-degree angle treatment in a single session is possible. Many a time it is combined with trabeculectomy, and it can be converted to trab in case we miss out on finding out the Schlemm's canal. Disadvantages being, yes, we are going through the conjunctiva, so there can be conjunctival damage. Angle may not be directly visualized, and few cases Schlemm's canal may not be able to find, and it is considerably longer procedure, and chances of hypotony slightly more when compared to goniotomy procedure. Certain complications are associated with this. There can be a DM stripping. Sometimes iris can get prolapsed. Iridodialysis or a cyclodialysis can happen when we swipe with the Ham's trabeculotome, and hyphema can occur. Blood-related complications can happen, and of course, cataract is another complication which can be encountered post-trabeculotomy. When we talk about combined trabeculotomy and trabeculectomy, that is one of the other common procedure which we do. It can be done without mitomycin C. Now, whether a combined trabeculotomy and trabeculectomy is more superior to only a trabeculotomy. So, Mandel et al. Had reported a long-term outcome of almost 300 eyes of 157 patients who underwent the combined surgery. The success rate was found to be 63.1, which is maintained until 8 years of follow-up. So, Al-Hashmi, he used mitomycin C. So whether to use mitomycin C or not, again, it's a controversy. So he used in his cases in primary combined trabeculotomy and trabeculectomy, and he had a good reported success rate of almost 80% to 85%. This is a small video of trabeculotomy. So once we do a conjunctival incision, a good pocketing of the conjunctiva is done. Cauterization of the conjunctiva. A flap is partial thickness flap is created. Once we created this partial thickness flap, then the most important step is to identify the Schlemm's canal. So many a time what we need to understand, if the baby has ophthalmos, identifying the Schlemm's canal is very important, because as I mentioned, there can be an anatomical variation. So we have to identify the Schlemm's canal. Usually it is at the margin of the white and the blue zone. And how do we identify whether we have entered the Schlemm's canal? Careful dissection and a sudden gush of the aqueous or a blood can understand that we are in the Schlemm's canal. Then we use the Ham's trabeculotome, which can be a right arm and the left arm, and then we introduce this into the Schlemm's canal and then swipe it into the anterior chamber. So when we do this movement, there should not be much of a resistance. If you are resistance, then we may not be the correct path. So once we do this, then we do this is a combined trabeculotomy, trabeculectomy procedure. After that, the trabeculectomy procedure is continued. The usual trabeculectomy procedure where we do a flap creation and the ostium creation and PI, and then the flap is closed and the conjunctiva is closed. So when we talk about only a trabeculectomy, as per the literature now, from which age is trabeculectomy good? So who are the best candidates? Which is the appropriate scarring agent and dose, and what to do when it fails? So when we search in the literature about the trabeculectomy in children, so most of the studies are of retrospective nature, and it's a different age groups, different techniques are being used, and the follow-up along with the regional and surgical preference bias is there. So it's it is more of a surgeon's discretion to take a decision when you go in for only a trabeculectomy. So usually in primary congenital glaucoma cases, when we have a failed angle surgery, we can think in terms of going for a trabeculectomy. If the surgeon is not comfortable to perform an angle surgery, or if any reason angle surgery is not possible, sometimes in case of advanced disc damage or to improve corneal clarity, when we require a low target pressures, we can go in for a trabeculectomy surgery, or when there is some indicators of poor prognostic factors for angle surgery. So usually 0.1 to 0.2 milligram per ml MMC can be used. A top-up agent with multiple 5-FU injections. Sometimes the only challenge is, again, we have to use these injections sometimes during the EUA examinations. How do we manage some of these refractory pediatric glaucomas? Again, we may have to do multiple surgeries like multiple trabeculectomies with MMC. And then we may have to perform bleb needling if the bleb failure is encountered. Glaucoma drainage devices as a primary procedure may not be very indicated, but definitely in refractory cases, drainage devices can be used. And lastly, there is not much of a visual potential, and if the kid has undergone multiple surgeries, in spite of all that, there is medical management is difficult, then we can think in terms of a transscleral diode laser photocoagulation. Of course, there should be a holistic approach to all these babies. Mandatory to correct the refractive error like myopia and astigmatism are very much associated with congenital glaucomas. Amblyopia management is extremely important, because after doing all this procedure, if the child doesn't get a useful vision, then the whole the exercise becomes futile. So it is mandatory to do a good visual rehabilitation. And of course, if the child requires a low vision aids, we have to help the children with these kind of low vision aids as well. These are some of my book references other than the journal references. Thank you.